Oh, that's right. I have to accept.
All right. Welcome to the third podcast episode of the Comfort Care Expert podcast, where nurses can learn how to provide high quality, compassionate end of life nursing care. I'm Megan Lifto, and I'm a palliative care clinical nurse specialist. And I'm joined by
Elena Prendergast. Today, we are actually diving deep into a topic, more Megan, that's pretty challenging, and it's crucial to providing comfort, especially to dying patients at this time.
It is. And so if you want a copy, we're going to be going off of the Comfort Care tool. And for your copy, you can go to my website, www.comfortcareexpert.com, and you can download a copy of it. And it's just as a refresher, it has the 5 most common needs of patients at end of life.
Yeah.
And we are finishing up the comfort section. So comfort is the first section. And then our next episode will be going to airway. But the focus of care for the dying patient, as you were saying, Elena, it's all about comfort. So all unnecessary procedures, tests, and activities should be evaluated. Providing as much time for the patient and family to be together should be the priority, and consider obtaining orders as appropriate for the following. So these are orders that you as the nurse can then ask the doctor or ask the healthcare provider to get for patients that are on comfort measures only. So patients that are actively dying and in the hospital and they're on comfort care. And so the first one I'll start with, Elena, is stop or modify assessing vital signs, meaning just do it once a day or spot check. Would you like to start and give why do we not need to do frequent vital signs on dying patients?
That's a great point. I mean, as you talk about ending all unnecessary procedures, tests, and activities, people never really think about vital signs. But we need to remember that the goal is to maximize the quality of life in their final moments and providing support to their families. So I think that's the really important thing that we have to focus on right now is that providing that support to the families means lessening their anxiety. And I don't know about you, but there is nothing more stressful than watching someone who really should be taking in those final moments with their family member watching the screen.
Yep.
There's nothing that's going to change at that point by watching our screen. I mean, I remember a story when I was a very young nurse, but I knew I was still passionate about this subject even then, was saying to the physician, are we just wanting to know like how slowly they die? Because the patient was on comfort measures and I wasn't trying to make light of it. But the fact that we were just sitting there watching this, and then watching the family watching it, it was actually honestly for me a little painful. I can only imagine how traumatic it was for the family, honestly.
Absolutely. Thank you for sharing that example because they do get, I've seen families get so fixated on the numbers too. Like, oh, they're at 86% oxygen. Do we need to start supplemental oxygen? That's something we're going to talk about in the next episode in a lot more detail about airway, about how somebody feels if they feel short of breath or dyspneic, they could be at a 97% oxygen. So it's
Right.
definitely that oxygen saturation is not a reliable indicator of someone's comfort. So we'll talk more about that. But it's just something, it's expected for somebody's blood pressure, for example, to go down as they are starting to die. And it's not that we would be starting vasopressors or any of these invasive treatments because it's what's the overall goal. The overall goal is just to promote comfort so that they can have a peaceful, dignified passing. And by not doing the vital signs, like it's okay to spot check, but especially things like pulse, I've found that if people can be uncomfortable with a very high pulse rate, like if it's 150 or something, then maybe they would need,
Right.
an opiate or a medication to help provide comfort. But yeah, overall, no need to be checking those vital signs more than spot checking.
Really, this is a time where nurses really excel, I think, because this is where we teach people who are not medical, in a very lay way, the dying process. And you brought up an excellent point about an expectation of a high heart rate, low blood pressure. We don't have to check that. We know that that's actually it's going to be an expected outcome. There's no reason for us to monitor that. We go back to the beginning of all nursing and medicine. We don't do anything that we don't plan on intervening on. What is
Yes.
the point of taking a blood pressure if, like you said, we have no intention of intervening in this process?
Yes, exactly. Yep. And then the next bullet point on the comfort care tool, it says to discontinue oral and all non-essential medications if the patient is unable to safely swallow. Do you want to start with that one?
Oh, I agree with you. This is another really important aspect, especially when we start talking about IV orders. When someone is nearing the end of their life, they have impaired circulation. We know that. So it's really important that we discontinue this, especially the rate of fluids. Otherwise, the IV fluids are going to cause what we all know as third spacing, right? And that's when the body fluids move to the body's interstitial spaces, including the lungs. That can cause a feeling of suffocation. We always want to be guided by that principle that says first, do no harm. And often we do fluids because we think we're actually helping. And in this particular case, if you understand the pathophysiology and our anatomy, you would understand that this is actually causing more harm than good at this point. I know for myself, it has caused distress, especially if you have somebody that has some medical knowledge, and some people do have enough medical knowledge. When they see that the fluids are running at 125 and that their loved one is third spacing, that can cause a very traumatic experience for them as well as the patient. And once again, we go back to the beginning. What we're talking about, a lot of this is not just for the patients, it is for our family members. And if we're doing something that is causing more harm than good, we need to explain, why we're doing what we're doing. Oftentimes, our family members think that we're starving their family member by not giving them fluids. And that's where a lot of their distress comes in. But if we did a better job of educating them on this particular process, they would realize that they don't want. Now, that's not to say that we might not give a small KBO, of keeping that vein open, just so that we could give some medications to the
Sure.
patient. If they're on in the hospital setting, as we know, we might see a continuous infusion of morphine. So that's definitely appropriate, but not continuous fluids, especially at high rates, other than the 20 to keep that vein open.
Yes, absolutely. I've had patients that I would walk into the room and I noticed that they would have chucks underneath their arms because they are third spacing. There's so much fluid that it actually, the water and fluids start seeping through their skin. And so that tells you right there that, yeah, it's not doing any good. It's not circulating because you had mentioned the impaired circulation. And so it's just, yeah, it goes out into their left arm or whatever arm
And
the
the
IV
lungs
has
get
it.
wetter. The
Yeah.
lungs get wetter,
And
which
the
then
lungs
causes
get
the other
wetter.
problems.
Yep. And I did want to jump back to where the discontinuing oral or all non-essential medications, things like vitamins, things that are we know that a lot of our older adult elderly people, they have something called a pill burden. They're so tired of taking so many pills that if as they are on comfort care, you can look at what are some non-essential ones that we can get rid of, like get rid of the big vitamins. You can get rid of the Lipitor or any of the other statins. Those are for
Yes.
long-term benefit, not the short-term benefit. And with discontinuing oral medications, yeah, if you're in the hospital setting, you have the IV route, or most medications can be given excuse me, via the rectal route too. But it's just something where we want to have their safety. We don't want them choking on pills, so that's why we want to look at and modify um, the route that we're giving medications as needed.
And by all means, discontinue anything that would be uncomfortable or cause discomfort. We don't see a lot of IMs, but we do still see some IMs being administered, and certainly we would want to discontinue something like that unless there are other routes, including respiratory, aerosol. We could
Yes.
utilize our respiratory colleagues to help us with some of the symptom management. So those are great points, Megan.
Yes, absolutely. And then going along with the circulation being impaired, it not only affects IVs, but it also affects if there's tube feedings running. So it says discontinue or reduce the rate of tube feedings. And if you don't mind, I would like to share a story with you of
Yes.
just a situation where the nurse just needed more education. But there was a gentleman who I was consulted on for palliative care just to have a goals of care conversation. As soon as I walked into his room, you could smell tube feeds, which I thought, okay, that's interesting. I don't recall walking in and smelling that. And then within just a couple of seconds, right? Because you should be able to get an overall status of your patient by looking at them. You don't even need to look at the machines. And I was looking at him, and he was having an increased work of breathing, and his lung sounds were so wet. They were so wet. And then he was coughing, and he had the Yonker suction, and it was
Yes.
actually filled with tube feeds. So this man was clearly aspirating on the tube feeds, and it's the same thing because the tube feeds goes into the stomach. But if the stomach and the intestines aren't working, because our metabolism gets so low when we die, so that's why we don't need to have, we don't need that nutrition. But yeah, it was doing the exact same thing. The tube feeds were just going into his lungs and then backing up into his esophagus. And so it was something where I had to provide education to the nurse because she hadn't picked up on those clues. I think we're just so used to just, up, we need this treatment. We're running so we can get nutrition. But yeah, it just alarmed me as not something that she could have picked up on right away. That if someone's coughing and you smell tube feeds, that's a sign that they need to be discontinued.
That, that's a great point. The other thing we need to remember, Megan, as we're talking about this, moving ahead, is turning off alarms and monitors,
Mhm.
DCing those lab orders, the isolation precautions. These are all practical things that we can do. They don't, I mean, they often require a order set, as we know, but often these are written into these. And it's really important that we remember these things because, once again, we're going to go back and we're going to continually going back to the impact on the family at this point, because we know oftentimes the family is the one who is really hyper vigilant right now. And that's not something that we've talked about, but I think all of us have experienced that. And that hypervigilance really has them, hearing so many things, and they're so in tune to sounds right now because their loved ones aren't speaking to them. So these alarms, while they may not sound very loud, they can be quite stressful during this time, because a lot of times I know we'll turn the volume down thinking that we're helping, but they still will be in tune to that. And so I think it's really important from that perspective. And then practically from the nursing perspective, is that we also recognize that all of these alarms cause alarm fatigue. And what we don't want is a nurse coming in who is fatigued from hearing other alarms, coming in really with not the right disposition, so to speak. And every time that you have to come in and turn off that alarm, you're also impeding or interrupting that process of dying. And there may be some work that's taking place, some closure that is taking place, that we don't want to intervene to do something that's just so practical as turning off an alarm on a patient that we know is, dying or in the actively dying phase.
Absolutely. And you bring up an excellent point with lab orders because I felt so bad for all the older adults, or I mean, even I've seen young adults need it too, but with those arterial blood gases, I mean, that needle is so long, it has to go in, it's so painful that's one that that I made sure was discontinued right away when we were starting Comfort Care. So it's like no more of those. And then if someone's not getting a blood transfusion anymore, there's no need to keep checking hemoglobin. There may be a case of if somebody wants, if they're on warfarin and if they're on hospice, say for, they have a wedding coming up in a week or two, they might check their INR for warfarin. But I mean, it's
Right.
very individualized care, but it's something, yeah, with the focus being on comfort, yeah, let's stop with the poking and prodding.
And let's clarify, we are talking about people that are in the imminently dying stage.
Yes.
We're not talking about people that are on palliative care where we may monitor some of these things, for their comfort, obviously. So that's something that definitely needs to be brought up. It's important to remember that as we're discussing this.
Yes, very much so. And then there are some orders that nurses do not need to have a provider order for. So so the following comfort measures nurses can provide without a provider order. And the first one is repositioning as needed for comfort and also to help drain copious secretions. So yeah, anyone respiratory wise, that's the worst thing you could do is have them lay flat on their backs. So yeah, repositioning, bringing them up to a higher position. Or if somebody does have, and we'll talk more about the secretions next week when we do our airway episode, but as you know, someone loses unconsciousness, those secretions are pooling because we still make saliva, but you just lose that ability to have that good swallow. So the secretions accumulate. And sometimes if you do reposition, like position someone over on their side, do some postural draining, it can help move those secretions around.
That's an excellent point that you make about repositioning. Repositioning can be huge when delivering comfort care. One of the things you talked about is that draining of secretions. It's also going to prevent discomfort and potential complications. Now, one of the things we haven't mentioned, which some people may or may not know or understand, is that Kennedy ulcer, where the skin can break down very quickly, very rapidly. However, barring that, there are things that we can do to prevent, discomfort to the skin and breakdown. And that is, of course, that repositioning, making sure we float those heels, making sure we really religiously are getting in there and turning that patient at minimum every 2 hours, actually, sometimes even every 1 hour. We really have to take our cues from the patient. So
Absolutely.
I agree with you. And that's also something that when families feel like they feel helpless, they feel like there's nothing that they can do. This is an excellent thing to teach your families how to do. Teach them how to reposition the patient. It's a very simple thing, but it very much makes them involved in the plan of care, makes them feel like they are empowered to take care of their loved ones in an environment where they really feel so out of control.
Yes, absolutely. I love bringing family members lotion, and if you have a little drop of essential oil, because then as they're, doing foot massage or hand massage, then the family member themselves are also becoming relaxed doing that activity. So that's another trick or something I like to do too. And then,
Absolutely. I mean,
mhm.
go ahead. I know you were talking about that touch. Can you talk a little more about that power of touch, Megan?
Yeah, so just the power of touch, it is that's touch and hearing are the last two senses to go. And so they are very much, you can relax somebody, you can provide so much comfort by just having a hand on their arm. Was there, yeah, it is. It's so powerful.
I love incorporating the complementary therapies, such as essential oils. That's a great point.
Yep. And another comfort measure that a nurse can do without a doctor's order is modifying the bathing. So instead of trying to get them into a shower, get them into a tub, you could provide a bed bath. Um, or you can
Great.
sometimes, or family members are like, nope, I don't want them to get a full bed bath. If turning is really painful for them, then you can discontinue the bed baths.
Yes. So one of the things we haven't talked about yet is reinforcing dressings That frequency of oral care, gentle suctioning. I know we alluded in previous episode about the suctioning, and then the cool washcloths. So when we think about that, we want to do the dressing changes as needed, rather than sticking to that daily wound care schedule. And this is a great time to collaborate. Just because someone is at end of life doesn't mean we get rid of our wound care team.
Absolutely.
However, it is important to make sure that our wound care team is educated on how to care for someone at end of life so that they don't have the perspective that it's aggressive wound care management. This is comfort wound care management. That's really important to emphasize. It's minimizing those unnecessary procedures, as a wound care regimen sometimes requires, is important. And we cannot underestimate at this time enough the importance of pre-medicating before we do any kind of dressing changes. Just because someone's at end of life, we don't stop doing that. So that's really important because that is a huge area of potential discomfort.
Oh, thank you for bringing that up. Yeah, so important is the pre-medication. Or even if somebody is painful while they're laying in bed, you pre-medicate a half hour before you reposition them. I do that frequently at the hospice house I work at. Yep. And it's important to help explain, for nurses to explain that modeling and cyanosis, it's not that the person they're cold and needs to be bundled up. It just means that those are signs of circulation changes. So when people do start, and not everyone models, I think there's some things that we think every person is going to go through the different stages, and not all of them do. Like if somebody's a younger person, they may not have the circulation issues that an older adult would have, where you see in elderly people, yep, if they're not moving a limb, you can see the purplish on the underside. But for for younger people, for older adults without circulation issues, I don't see it as much. And you can notice sometimes that the lips will turn kind of purplish or kind of dusky looking.
Megan, I'm glad you brought this up. I think in particular, I'd like to speak to the new nurses, when we're discussing this here as a person in educating nurses. One of the deficits that we found is many of our nurses in nursing school may not actually experience this. They may not have seen modeling before. And if you're in the critical care setting, you start to panic, because you see this and you're like, I've got to do something about this. I remember a brand new nurse, when was fairly new nurse practitioner, that was sitting there and was asking, like, we need some pressors, we need this, we need that. And finally the intensivist was actually caught up with something else, and he figured out what was going on. I was kind of walking into it and figured that this nurse had never experienced or seen this, and didn't know what was going on. And so I asked her, I said, have you ever seen a patient die? And she just looked at me and said, no. And she did not even realize that the signs that she was seeing. So, one of the things that we had talked about doing, because it's not easy to understand what this is unless you've seen it, is getting nurses out there and exposed to this, fairly early on so that they can understand what this looks like. Because if they don't understand that this is all part of the whole process, it can't be taken independently. And so we can't just look at it, because this could just be someone that has poor circulation, but you have to understand the subtleties. And that's why, and I know you and I are passionate about this, frequent assessments are important. Just because you have a patient on comfort measures does not mean that you don't go over there. You can only understand by seeing their baseline and then noticing the subtle changes, that come with the dying process. And that's really what we're trying to do here, is educate them on that. And so it is
Absolutely.
important for us to reiterate that.
Absolutely. No, thank you so much for bringing all of that up. And that right there is just what the last part of the comfort section of the comfort care tool. And so what we're going to do is we're going to be ending this episode. We'll have airway, we'll be on the next one. But keep on advocating for your patient's comfort. Stay kind, stay compassionate, and most importantly, take care until next time.
Goodbye, everyone.
Bye.